I'm Dr. S.S. Honnani, surgical gastroenterologist. Today I'm going to speak about GERD or Gastroesophageal Reflux Disease. What exactly it is? We have food pipe, something called esophagus and the stomach. The junction of the stomach and the esophagus usually will be always closed. Whenever we eat food, that part will open up, and once the food passes, it will get closed. What will happen is none of the gastric content will reflux back into the esophagus. Whenever normally it will happens to everyone, only when the pressure in the esophagus like stomach becomes more than the pressure in the esophagus, then only reflux will happen. In the patient with GERD, this mechanism will be lost. So that lower sphincter will become weak and lax, so that whatever the content in the stomach, that will come back to the esophagus and will cause discomfort. A patient with GERD, usually they present with retrosternal burning, means burning sensation behind the chest cage and behind the rib. Sometimes they have throat irritation, sometimes they will have voice change, and most of these patients will be having disturbed sleep, because when they lie down, the food reflex will be coming back to throat and it will affect their sleep. Some patients even presents with the features of acute attack of asthma. So many a times I get lot of references from pulmonologists that it is not asthma, please go through this patient and kindly rule out GERD. Why you need to worry about GERD is, whenever this reflex happens continuously, this acid content in the stomach will cause irritation in the esophagus and it will cause ulcers, and it is called as reflux esophagitis. It can be graded into grade 1, grade 2, grade 3, grade 4. Based on how severe is the reflux, like that esophagitis will develop. So with the problem with the esophagitis is there, when it is there for a very long time, it can cause cancer of the esophagus, usually adenocarcinoma in the lower end of the esophagus. So we have to take GERD very seriously. Now, how do we evaluate a patient with GERD? Usually when a patient presents with these symptoms, we usually straight away advise to get an endoscopy done. Why endoscopy is? Like, it will clear cut tell whether reflux esophagitis is there, what is the length of the esophagus, and what is the grade of the hiatus hernia, or how bad is the situation. Now what I usually face is, whenever we advise endoscopy to the patient gets scared. Doctor, how I can do? I'm get scared. What will happen? No, like, this is a very minor OPD procedure and usually doesn't require any anesthesia. Only requirement is patient should be empty stomach for minimum 6 to 7 hours. And after that, when the patient comes, we just spray some local anesthesia to the throat, or sometimes we give a gargling solution to gargle. When they gargle, throat becomes numb, then we do the endoscopy. The process of endoscopy hardly takes 10 or 15 minutes. But it gives lot of information. It gives whether reflux esophagitis is there, what is the grade of the reflux esophagitis. Also, it will tell about the disease per se, like what is the grade of the hiatus hernia, it is grade 1, grade 2, grade 3 or grade 4. Why it is important is, entire treatment plan will be based on findings of the endoscopy. Once endoscopy is done, once the disease is classified, usually patient with grade 1 and grade 2 hiatus hernia, we manage conservatively. How we manage is, first we give the medications to suppress the acid, and also we give some pro-motility drugs. And once this is done, we give a predominantly dietary advice. The most important thing is, they have to eat multiple small meals. They should not eat full stomach, they should eat only half stomach, and whatever the heavy meals are, non-vegetarian meals or heavy meals, it should be taken in the morning or in the afternoon. Dinner should be very light, maybe like simple easily digestible food like breakfast, like idli, dosa or some salads, and they should finish their dinner at least 2.5 hours before they are going for bed. We assess how patient is responding. If patient is responding well, dietary modification will help to control the disease. If patient is not improving with the medication and dietary advice, then we have to think about the intervention. Usually, if patient has endoscopic feature having extensive reflux esophagitis, even in grade 1 or grade 3, grade 4 hiatus hernia, these are the patients usually may not respond to medications, and these are the patients who have high risk of developing esophageal cancer. For them, we advise either endoscopic or laparoscopic procedure. And the endoscopic procedures cannot be offered to a higher grade hiatus hernia, like grade 3, grade 4 hiatus hernia. It is useless. For a laparoscopy, what we do is, is whenever we have a patient who is not responding to medical therapy and whose lifestyle is affected significantly, or who are having asthma kind of attack, or having throat irritation. When endoscopy they are having reflux esophagitis of grade 3, grade 4, or any Barrett esophagus, these features are there. These are the patient we subject them to laparoscopic fundoplication. In the laparoscopic fundoplication, either we do a partial fundoplication or a complete fundoplication, but choice of surgery will be decided by the surgeon based on their manometry findings. Before surgery we get esophageal manometry. If manometry shows esophageal motility is proper and swallow quality is good, then we offer them complete fundoplication. If the esophageal motility is suboptimal, not very good, then we do a partial fundoplication. Most important aspect of getting surgery done is it will cure the GERD completely. More than curing, it will negate the risk of developing cancer in future. Whenever you have a GERD, kindly go to your surgeon, have a detailed discussion and plan about treatment options, and each treatment has to be planned according to the patient. Sometimes we have a grade 1 hiatus hernia but they have extensive esophagitis, we advise straight away surgery. Some patients will have grade 4 hiatus hernia and they don't have any reflux esophagitis, they are not very symptomatic, then we manage conservatively. Age factor also important. If patient is very young age and they are having hiatus hernia, usually any hernia, as it is a progressive disease, over a time they develop what is grade 1, grade 2 may become grade 3, grade 4. In these cases, if they are having severe symptoms early young age, we advise surgery, because number of years they are going to survive, number of years they are going to expose to risk of cancer is more. Same day, if patient comes with a 50 or 60-year-old, 70-year-old and they are having even the grade 4 hernia, mild symptoms which can be managed with the medications, we don't actually offer surgery because we see the risk assessment issues. Unless it is affecting their lifestyle very badly, then only we offer the surgery in an older age group. In a younger age group, even if mild symptoms, we advise them to get surgery done. Only reason is the number of years they are getting exposed to acid reflux, the risk of developing cancer is more high. So in these patients, to avoid developing cancer, better to get a surgery done. My sincere advice for people is, whenever you have a hiatus hernia, GERD symptoms, meet the surgeon, discuss your treatment options and then take a call what has to be done.